this is going to sound like a made-up story, but it's not, because it would be too transparent for me to make up such a story. But an hour before we began this broadcast and taping, I was on a FaceTime with a friend of my, one of my children, who she herself is an overachieving surgical fellow who also is trained in critical care, who was diagnosed with de novo metastatic breast cancer, sadly. And she's had a great response to initial therapy with about 18 weeks of weekly paclitaxel with intravenous trastuzumab and pertuzumab. And again, literally an hour before this call, we were on FaceTime discussing the path forward, and her doctors are appropriately prepared to transition her to just continuing on the antibodies alone, as well as anti-estrogen therapy appropriate to her disease biology. And this led us to have this discussion about Phesgo and what it is, and why should we feel comfortable and confident that a subcutaneous administration is a safe substitute for intravenous, because I know some patients worry about that.
Well, that's a question that comes up, and patients will say, how do I know it's going to be the same? What if it doesn't work? What if it fails? And, it's so nice to be able to say that we do have a clinical trial. It was a phase 3 trial called FeDeriCa that actually looked at that question. And maybe we could take a few minutes and speak to that, where patients were randomized. There were about 250 patients in each arm, randomized to their chemotherapy, which was an anthracycline-based chemotherapy, transitioning then to either IV anti-HER2/neu antibody treatment with their taxane versus Phesgo with their taxane. And I think so interesting that these patients went to surgery and then they were maintained on Phesgo or IV pertuzumab. And there were some really interesting primary endpoints there. Number one, looking at whether there was non-inferiority. And Andy, I think you can speak to that.
Yeah,
with the primary endpoint. Yeah.
Yeah, this was kind of the central study that led to the regulatory approval, and it set out to accomplish two tasks. One was a pharmacologic endpoint, and that was simply to determine whether the trough levels of the antibodies, whether the drugs were given intravenously or subcutaneously, were similar and at least non-inferior. And indeed, that is what was observed both for trastuzumab and pertuzumab. I believe it was after the seventh dose.
After the seventh dose of each of the antibodies, and it actually exceeded expectations.
Yeah. So numerically, I think it was actually higher for the subcutaneous than intravenous. So that was part A, and then part B was in the preoperative setting. Is there any detectable signal in the possibility of losing efficacy? And the path CR rate, of course, is the metric there of interest. And the path CR rates, I think, were identical. They were basically about the same. So there was no concern from that trial that subcutaneous antibodies was going to be any less effective and pharmacologically equivalent.
They were fairly identical, with the Phesgo 59.7% and with the IV preparation 59.5%. So that trial really settled some of the agita that patients were having and some physicians were having also, as well as nurse practitioners and PAs who were taking care of these patients. So that was settled. But then what about patients? What did they prefer? And there was a trial, again, that tried to answer that question, and that was the FeDeriCa trial. And that was an interesting trial because it allowed patients to be exposed to both avenues of anti-HER2/neu administration, where patients were treated with IV for X amount of cycles and then transitioned to the subcutaneous, or the reverse, starting with subcutaneous and then flipping over to IV. And really recording patient preference. After X amount of cycles, after 6 cycles, patients were allowed to pick how they would like to continue, whether IV or subcutaneous. And does anybody know the stats on this? Yes, there you go. Go ahead, Christine, it's all yours.
Of course, they preferred the subcutaneous route. I mean, it was generally well tolerated. You know, there was no safety concerns when even from switching from one modality to the next. They found it quicker than IV. And yeah, most patients preferred sub-Q over IV. It was less time consuming. There was, you know, minimal side effects, just really the injection site redness, you know, reduces chair time for the patient, the clinic, all that. So yeah, patients preferred subcutaneous.
Yeah, 85% of patients preferred subcutaneous.